To introduce our next plenary speakers, please welcome to the stage Her Excellency, the First Lady of Namibia, Madame Monica Gengos.
Good morning. When I listened to Charlize Theron speak about privilege, I had to review my own, because the reason I'm standing in front of you today is because I married a head of state. Now, first ladies in general, the only real power we have is that we don't have to make an appointment to see the president. So, but as Charlize said, with any privilege comes responsibility. So anybody who has proximity to power, which many of you have, you need to use it responsibly. And as many First Ladies in Africa, and that's why we have the Organization of African First Ladies Against AIDS, we use our proximity to power to address difficult social issues. One, and the obvious, being HIV, particularly to the extent that it affects adolescent girls and young women. One of the things, like with Charlize, that First Ladies have, you have immediate social capital. So once you become a First Lady, you become immediately popular. And once you're no longer First Lady, you're not popular anymore. So while you're popular and you have social capital, like with any capital, you have to spend it. So you have to spend it talking about difficult topics, especially in an African context. One of the difficult topics that we see increasingly is the way that inequality interacts with every single social reality we have in our country. It's easy to speak about HIV, but it's not so easy to speak about how inequality drives that, how adolescent girls and the relationship with transactional sex is driven by poverty. So if we don't fix these structural inequalities that we have, we're not really going to make ground in preventing adolescent girls and young women from being exposed to HIV, particularly by older men. So when we speak about the human rights-focused approach of HIV, we also need to speak about how it's driven by poverty, inequality, and the need to transform our economies so that they start to reflect the demographic diversity of our nations. It's against this backdrop that in our global quest towards a more effective HIV response, we remain steadfast in our efforts to shift from focusing solely on HIV/AIDS and working more generally towards a more inclusive and transformed economic structure, while also integrating health systems and strengthening them. This will also require that besides government and development partners, that civil society and HIV activists expand on the gains of the HIV/AIDS response and promote a rights-based response to other health issues and economic issues in ensuring that we leave nobody behind. With these few words, it gives me great pleasure to introduce Anna Derabayina from Kazakhstan, as well as Olena Strezek from the Ukraine, to speak to us about their experiences.
Thank you. Good morning. I'm honored to participate in the plenary and talk about different ways we can optimize HIV prevention and treatment outcomes for people with substance abuse. In my presentation today, I will talk very briefly about the magnitude of substance use in HIV globally, intersection between substance use and HIV, different service delivery models to optimize HIV cascade for people who inject drugs, as well as challenges to effective HIV epidemic control in this population and ways forward. So it is estimated that 250 million people in the world use drugs, with distribution of use of specific drugs noted in the figure on the right. Almost 30 million people suffer from drug use disorders, and approximately 13 million people inject drugs. In addition, more than 3 million people die from harmful use of alcohol every year. There is a strong link between HIV and substance use that is also supported by epidemiological data. It is estimated that as much as 1.7 million people who inject drugs are living with HIV. As you can see on the graph, on sub-regional level, countries of South and Eastern Europe have both one of the highest number of people who inject drugs, represented by the green outer circle, as well as the number of people who inject drugs who are living with HIV, represented by the white inner circle. Use of drugs is associated with increased risk of sexual transmission, with people who use psychoactive substances are more likely to practice risky sexual behavior such as unprotected sex and sex with multiple partners. In addition, it is estimated that people who inject drugs have 24 times higher risk of HIV acquisition compared to general population. Along with the increased risk of contracting HIV, use of opioids may lead to increased immunosuppression among people living with HIV, causing higher rates of opportunistic infections, including tuberculosis. The impaired judgment and mental effects of substance use also create difficulties in maintaining a consistent HIV treatment. And finally, stigma and discrimination associated with the use of illicit drugs often create significant barriers for people trying to access HIV prevention, care, and treatment services in many countries around the world. On this slide, you can see some data to support the observations I just shared with you. The table here shows the results of a retrospective cross-sectional analysis of routinely collected data on ART-naive patients that started therapy in Kazakhstan. Reporting injecting drug use and harmful alcohol use were associated with discontinuation of therapy within the first 12 months of ART initiation. Beyond opioid dependence and alcohol use, use of other substances has also been associated with risk of HIV. Several studies have shown that sexualized drug use, or chemsex, practiced by gay, bisexual, and other MSM increases risk of HIV transmission and reduces ART adherence. In the table on this slide is an example of one recently published study from 2 clinics in London. As you can see in the middle column, the percentage of men reporting risky sexual behaviors and injecting drug use was higher among those reporting chemsex. Key populations face particular challenges from the perspective of both HIV prevention as well as HIV care continua. Starting on the left on this slide is the bar in dark blue representing key populations. As you will note, moving from the left to the right of the slide, there are multiple steps where challenges are faced in engaging such populations, from reaching them to accessing to HIV testing, enrolling them in care, initiating IRT, and achieving and maintaining viral load suppression at the end of HIV care continuum. This graph demonstrates the difference between HIV care continuum, contrasting it among people living with HIV who inject drugs, the column in red, with people who did not report injecting drugs, the column in blue. People living with HIV who inject drugs tend to be enrolled in HIV care less often and are less likely to be effectively initiated and retained on ART compared to those who don't. I will focus now on some innovations to address the gaps in this continuum. Making sure people know their HIV status is the first step in the cascade. An approach to optimizing HIV case finding was implemented by the Alliance for Public Health in Ukraine, which can serve as an example of a potential solution to increase HIV testing coverage among people who inject drugs. The model is based on conditional chain referral sampling, where HIV-positive individuals identified through harm reduction programs are incentivized to refer their peers for HIV testing. Recruitment stops if two HIV-negative cases are consecutively noted in a chain. This model allowed reaching people that were not using the existing harm reduction services before. Thus, as you can see here at the bottom of the slide, while the HIV testing yield for standard outreach program was 1 to 2%, the optimized case finding increased the yield to up to 16%. And more than 60% of people living with HIV who were newly identified as part of the intervention had never been tested before. Another approach that holds promise as a way to reach people who are not accessing existing HIV services, including people who inject drugs, is HIV self-testing. In this figure, which shows findings from a study conducted in Vietnam, presented at IAS 2017, the findings were really encouraging. The results showed that HIV self-testing was acceptable among people who inject drugs. As shown here, learning how to use the test and privacy and confidentiality of HIV self-testing were the key reasons for people to choose HIV self-testing. Another example of innovations for case finding is shown on this slide. Getting young people experimenting with different drugs engaged in harm reduction in HIV testing services is another challenge to ensure effective HIV cascade. The Alliance in Ukraine recently launched a novel intervention that specifically targets young people experimenting with different drugs. It's called Drugstore, and it provides access to online counseling and information about sexual health, substance use, and HIV testing. To attract use, the program will soon start providing a drug check-in service to inform the users about the composition of the drugs and therefore advise them on less risky taking of said substances. But now let's move to innovations to support adherence to ART and viral load suppression, a challenge faced by many people who inject drugs living with HIV. In 2018, ICAP at Columbia University in Central Asia launched a nurse-led home-based adherence support intervention targeting people living with HIV who were on IRT for 6 and more months but did not have viral load suppression. In this figure, you can see the percentage of these patients that achieved viral load suppression after just 3 months of participating in the program. In red are figures for people who inject drugs, and in blue for people who did not report injecting drug use behavior. As you can see here, in Kazakhstan and Tajikistan, the proportion of patients who became virally suppressed was even higher among PWID than among non-PWID, showing the effectiveness of this intervention in ensuring viral load suppression among all patients, including people who inject drugs. Of course, these are early data, and more long-term data are awaited. Opioid agonist therapy or opioid substitution therapy, OST programs, are not novel. From a number of meta-analyses published back in 2011-2012, we know that OST decreases HIV transmission and HIV incidence among people who inject opioids by reducing injecting drug use and reducing sharing of injecting equipment. A more recent report, a systematic review and meta-analysis published in 2016, also found strong evidence of the positive impact of OST on ART initiation, ART adherence, viral load suppression, and ART discontinuation. The same study also found that OST markedly improves the HIV prevention benefit of ART for prevention. Another intervention aimed at enhancing ART initiation and virus suppression among people living with HIV who inject drugs is integration of OST and ART service delivery. On this slide, you can see results of integrated delivery of HIV and OST that is supported by ICAP at several sites in Kazakhstan and Tajikistan. Intervention sites are shown in blue columns and non-intervention sites in red. On the left side of the figure, you can see that after 4 years of implementation, the proportion of people living with HIV on OST and ART increased both for prevention and for intervention and non-intervention sites. However, on the right side of the figure, you will note that the proportion of people living with HIV on OST and ART that were virally suppressed increased over time in intervention sites, but decreased in non-intervention sites. Excited results were presented at CROI earlier this year from 2 studies that showed a positive effect of extended-release naltrexone on viral load suppression. Naltrexone is an opioid antagonist that's available in long-acting formulations. Both studies were multi-site, double-blind, placebo-controlled trials that compared extended-release naltrexone with placebo among incarcerated people living with HIV with opioid dependence or alcohol use disorders, transitioning to community over a 6-month period. On the left side of the figure, comparing naltrexone arm in dark blue with the placebo in light blue, you will note that there was an increase in viral load suppression in the naltrexone arm from baseline to 6 months at both thresholds of less than 50 copies per milliliter and less than 200 copies per milliliter. On the right side of the figure, you will note that persons in the naltrexone arm were more likely to improve and maintain viral load suppression compared to those in a placebo arm, whereas more people in the placebo arm achieved viral load suppression. But now, what about the HIV-negative prevention continuum for people who inject drugs? There is a lot of global excitement now regarding the promise of pre-exposure prophylaxis, or PrEP, for prevention of HIV acquisition among individuals at substantial risk. The Bangkok PrEP trial, among a large cohort of prospectively followed people who inject drugs, published in 2013, demonstrated 70% reduction of HIV acquisition risk among PUID with detectable tenofovir levels, as noted in the table on the right side of this slide. However, implementation of PrEP among PUID is still very rare. On this slide, you can see a cover of a report from several consultations with people who inject drugs conducted over the past 2 years. Results of these consultations show that PrEP is not always supported by this population, fearing that its implementation may shift the focus away from harm reduction initiatives, such as needle and syringe program, OST, and naloxone. So while innovations are urgently needed to confront the threat of HIV among substance users, there is an equally urgent need to expand what we know works, existing evidence-based interventions. According to a study published in 2017 that included a review of published and read literature, less than 1% of people who inject drugs lived in countries with high coverage of both NSP and OST. Countries with higher numbers of PUID, including China, the US, Myanmar, Ukraine, and several other countries from Eastern Europe and Central Asia, including Kazakhstan, where I come from, had low NSP and low OST coverage. Of particular concern, Russia has an estimated 1.9 million PUID, 30% of whom are estimated to be living with HIV. This was and still is the only country in the Eastern European region that does not provide OST, and access to NST is still very limited. So to achieve HIV epidemic control globally, we need innovations and new models how to optimize HIV prevention and treatment for PUID. Ultimately, to reach and engage people with substance use disorders, there is a need for tailored services and interventions that we call differentiated service delivery, DSD. On the left side of this slide is a list of necessary elements of such services for all PUIDs, and on the right, additional services specific to HIV-positive and HIV-negative people who inject drugs. In many countries, we need political will to ensure access of people who inject drugs to basic harm reduction interventions, such as needle and syringe programs and opioid maintenance programs. In places where services are available, there is a need to bring them to scale and to achieve the necessary coverage. People living with HIV must be enabled to access effective antiretroviral therapy and receive adherent support regardless of their substance use. So in conclusion, reaching high coverage for prevention and treatment remains a challenge for people with substance use disorders. There is an urgent need to provide combination of evidence-based biomedical, behavioral, and structural interventions in a manner that is appropriate and sensitive to the need of the populations to be served. Designing, implementing, and evaluating DSD models is a critical priority for this group. We also need to ensure that all interventions are developed and implemented with active community engagement and support to understand specific needs of target populations and subpopulations, like, for example, substance-using youth and women, and the challenges they face when seeking healthcare services. Finally, human rights must be prioritized over political agendas and rigid moralistic attitudes. Thank you. And on that note, I would like to hand over to Lena Strizak, who will talk more about the community involvement. Thank you.
I am HIV-positive woman. I got infections through drug injections and shared needles. At the time of infection, I had no knowledge about HIV. Reasonably, I strongly support comprehensive, gender-oriented harm reduction services that have proven to be highly effective in prevention HIV and other diseases. We need to keep track and strengthening efforts in harm reduction because without it, HIV epidemic cannot be stopped, nor in our region, neither in globally. Decriminalization of use and possession of drugs, adoption of supportive legislation framework for harm reduction is vital for reducing HIV transmission. Despite of all pledges of combat AIDS among people who use drugs, scale and scope of harm reduction services remain extremely insufficient. 68 out of 155 countries where injection drugs use is reported still not provide needles and syringes program, while opioid substitution therapy has been initiated in only 3 new countries. Harm reduction is underfunded. In 2016, the allocated amount for harm reduction projects was 15 times less than it needed. Less than 8% of global spending for drug control directed to harm reduction can decrease number of new HIV cases and HIV-related deaths for more than 90% by 2030. An estimated $100 billion is currently spent on global drug enforcement and control, while only $160 million is spent on harm reduction. We call on member states to redirect 10% of their annual drug control spending towards harm reduction to reach higher coverage of life-saving services. Recently, new psychoactive substances become seriously a challenge for the national public health system, local NGOs, communities in the region of Central and Eastern Europe and Central Asia. Use of new psychoactive substances has led to new threats for health: overdose, psychotic reaction, high HIV risks due to multiple injections, increased number of sexual contacts and likeliness of unprotected sex. However, in many countries, service providers are not ready to deal with use of new drugs. Use of new drugs is typical for young men and women, but other age groups can be also involved. They are cheaper than natural drugs and more attractive and affordable for young people. OST and Aloxone provision are not effective. Needle and syringes program are relevant for new psychoactive substances, but the number of syringes needed is considerably higher than in case of opioid use. We suggest a list of effective harm reduction intervention targeting those who use of new psychoactive substances. Provision of information about each substance available on local drug scenes and its side effect to drug user and service providers. Make services available in nightlife settings. Provide drug tests for harm reduction clients and in nightclub to ensure users know what they consume and are empowered to make safe choices. Good coverage of existing needle exchanging services and increase the number of syringes per person for those who inject new psychoactive substances. Promote self-help and exchange reliable information between users. Promote drug consumption rooms. Establish close cooperation between toxicological laboratories and medical institutions, providing care to users in cases of overdose. Train service providers, including ambulance staff, in particular, how to communicate with the new psychoactive substances users and educate them about new substances. Even when HIV prevention services are available, the quality of programs is often inadequate. As a result of there is late detection, poor retention in care, hence leading to increased morbidity and mortality. There are examples of good practices from around the world that can be used for planning programs and services for people who use drugs. People who use drugs in all their diversity need engage in strong, focused advocacy and negotiated with decision makers to address these significant challenges, as well as continue to fight for their right to engage in the planning, implementation and monitoring of national HIV responses. Compulsory drug detention centers are common throughout Asia. At the same time, treatment methods such as OST are generally unavailable on these settings. Comprehensive analysis of outcome of treatment in different facilities in Malaysia showed that relapse rate among patients completed treatment in compulsory drug detention centers is significantly higher than in voluntary centers. In many countries, HIV prevalence among women who inject drugs is significantly higher than in men, especially where harm reduction services are not widely available. In Eastern Europe, less than 1% of women who inject drugs have access to OST. Moreover, access to sexual and reproductive health services is very limited for them. Vertical transmission of HIV among women who use drugs is significantly higher than among other women living with HIV. Gender inequality and punitive legislation affecting women who use drugs reinforce each other. Structural gender inequality impedes the development of effective drug policies and adequately address the right of women. Violence and stigma and stereotypes faced by women who use drugs are accelerated. Little attention has been paid to gender differences in drug use. 1/3 of all people who use drugs are women and girls, yet only 1 of 5 of those who receive treatment are. Although men are more likely to use drugs, the combined harm and risk connected to drug use are higher in women. Women living with HIV who experience violence are less likely to access HIV care and participate in HIV prevention and drug treatment services. In addition to this, data suggests that the addiction progresses faster among women than among men. Clinical trials and in research are largely centered on men. More research is required for studied biological impact of drug use on women. The experience of women who use drugs and those living with HIV is compounded by poor access to maternal health care and other human rights violations. Women face greater barriers than men to accessing drug treatment and rehabilitation services. In addition, stigma leaves women who use drugs reluctant to seek medical services. Harm reduction programs rarely support women's personal safety and confidentially, do not provide sexual and reproductive health services or prevention of vertical transmission and child care. National responses to people who use drugs are often retributive. We advocate for the decriminalization of people who use drugs and calls for policy reform to guide treatment and prevention. Draconian laws in many regions, particularly in Eastern Europe and Asia, continue to punish and imprison women for possession and use of drugs. Women who use drugs are afraid to protect own rights. In 2016, the UN General Assembly Special Session on Drugs called for gender mainstreaming in drug policies and stressed the need to involve women at all stages of development, implementation, monitoring and evaluation of drug policies and programming. The UN rule, so-called Bangkok Rules 2011, reinforced the importance of gender-sensitive policies on people who use drugs. Although these policies oblige member states to implement gender responses in drug policies implementation lags behind with little reform and no consideration to scale up gender-sensitive drug policies. A few countries made law reform. For example, Bolivia made this year changes in criminal code and reduced sentences for women. We need governments to undertake following steps: provide funding and ensure access to comprehensive health care services, including sexual and reproductive health, hepatitis, HIV prevention strategies, especially in prisons. Develop mechanisms that guarantee personal safety and privacy that allows women to report incidents of violence without fear. Ensure cases of violence and any unlawful actions are investigated, including those committed by healthcare providers, social workers, law enforcement officials. Provide access to state legal assistance for women who use drugs in case of violation of their rights. Engage women who use drugs monitoring of progress in implementation of recommendation made through UNGAS policy around gender in drugs policy. Improve legal framework to ensure continuous substitution therapy for women who use drugs. Secure access and availability to integrate services including support and OST during and post-pregnancies. We need researchers to capture the diversity of women who use drugs and that recognizes the intersectionally within different population of women who use drugs. Focus on women who use drugs, including LGBTI communities, women who are in prison, women living with HIV, and sex workers. We need donors too. Encourage countries to support human rights and evidence-based intervention for women who use drugs, strengthening the capacity and engage women who use drugs in Global Fund-supported programs. Support community-driven research that collects and explores qualitative data to address and improve the lives of women who use drugs. And at the end of my presentation, I would like to stress that in war on drugs and combating HIV epidemic, often regular people suffer, and most of them are women. Chase the virus.
Not people.
Chase the virus.
Not people.
Chase the virus.
Not people.
To introduce